In this course we will delve into the anatomy of jejunum and ileum, the longest part of the gastrointestinal tract. We will start with an introduction to the jejunum and ileum, presenting their limits inside the gastrointestinal tract as well as their common function. Following that, we will focus on the descriptive anatomy of the jejunum and ileum, including their general aspect and particularities. Next, we will take a closer look at the layered structure of their wall that follows the general structure of the gastrointestinal tract wall with some special features. Moreover, we will take a look at a major portion of peritoneum that constitutes the support of jejunum and ileum, the mesentery. Then, we will explore the anatomical relations of the jejunum and ileum. Afterwards, we will proceed to describe the blood and nerve supply and lymph drainage of this part of the intestine before summarizing. The jejunum and ileum extend from the duodenojejunal flexure to the ileocecal junction. The jejunum constitutes the upper 2/5 of small intestine and the ileum the lower 3/5. They are situated in the infracolic compartment of the peritoneal cavity and play a major role in digestion of aliments and absorption of nutriments. They both belong to the midgut and represent the mobile portion of the intestine. The jejunum and ileum are very mobile, 15 to 16 coils hanging free on the mesentery. The jejunum is wider bored and thicker walled than the ileum. The wall of the jejunum is thick and double while the wall of the ileum is thin and single. This distinction can be made by rolling the wall of the intestine gently between finger and thumb. The lower reaches of the ileum are distinguished by the presence on the antemesenderic border of elongated whitish plaques in the mucous membrane, usually but not always visible through the muscle wall. Each coil is U-shaped, concave towards midline. The branches are in contact with each other. The jejunum and ileum are 5 to 6 meters long. It corresponds to the length of the free margin of mesentery. The root of mesentery is 15 centimeters long. The internal diameter of jejunum is about 4 centimeters when of the ileum is 2.5. The jejunum and ileum are hollow columnar coiled tubes. Each coil has 2 convex faces and 2 borders. The anterior border is the antemesenderic free border and the posterior border corresponds to the intestinal border of the mesentery and constitutes the point of reflection of the serous coat of intestine forming the mesentery. An ileal, Meckel's, diverticulum is present in 2% of individuals, 60 centimeters from the cecum and is 5 centimeter long. Its blind end may contain gastric mucosa or liver or pancreatic tissue. It represents the intestinal end of the vitellointestinal duct, and its apex may be adherent to the umbilicus or connected thereto by a fibrous cord, a further remnant of the duct. Ulceration and perforation of the tip can occur. Let's, now, examine the wall of this portion of the gastrointestinal tract and what is special about it. The wall of jejunum and ileum is formed of 4 layers. The serous coat is the outer layer. It covers the anterior board and convex faces of each coil, continues up behind and is reflected downwards to the floor of posterior abdominal wall. The muscle layer is made of 1 longitudinal outer layer and 1 circular inner layer and contains the myenteric plexus of Auerbach. The submucosa is a loose areolar connective tissue that contains the submucous plexus of Meissner. The mucosa is a simple columnar epithelium. It contains the glandular crypts of Libicon made of enterocytes and a muscularis mucoae. Its macroscopic aspect is formed of semilinear folds and, microscopically, the epithelium covers finger-like connective tissue cores of lamina propria called villi. These villi contain capillaries when intestinal absorption occurs. In the distal reaches of ileum, lymphoid follicles aggregate in the lamina propria and form Peyer's patches. One physiological feature about these last reaches is that they represent the unique portion of the gastrointestinal tract that holds the intrinsic factor receptor without which vitamin B12 cannot be absorbed, which exposes to a myriad of pathological phenomena. As the jejunum and ileum are very mobile, it is preferable to present the mesentery as the peritoneal fold rather than a support to the jejunum and ileum. The mesentery is a 2 layers peritoneal fold adhering to the posterior parietal peritoneum that covers the jejunum and ileum as they constitute the free mobile portion of the intestine. The route of mesentery passes down from left to right at an angle of about 45 degrees. It begins on the left at the duodenojejunal junction, crosses the third part of the duodenum where the superior mesenteric vessels enter between its two layers, and then continues downwards across the aorta, inferior vena cava, right psoas muscle and ureter to the right iliac fossa. It ends in its intestinal border at the mesenteric border of each coil. The mesentery is highly folded and its depth, from root to gut, is about 15 centimeters. It supports the blood supply and lymph drainage of the jejunum, ileum and large intestine. The infracolic compartment is divided into two by the attachment of the root of the mesentery. The upper part is right and the lower part is left and contains the major part of the small intestine. The jejunum and ileum remains superficial. Thus, forwards, they are covered by the great omentum and the anterior abdominal wall. Backwards, the jejunum and ileum are in contact with the retroperitoneal organs through the posterior parietal peritoneum and mesentery. At the top, they are overlaid by the transverse colon and mesocolon. At the bottom, they overlay the sigmoid colon, rectum and pelvic organs. Laterally, on the right, the ileum lies next to the cecum, ascending colon and the lateral abdominal wall, and, on the left, the jejunum next to the descending colon and the left lateral abdominal wall. Let's, now, have a look at how this portion of gastrointestinal tract is supplied and, consequently, how absorbed nutrients join blood circulation. Numerous jejunal and ileal branches arise from the left side of the superior mesenteric artery and enter the mesentery by passing between the two layers of the root. The jejunal branches join each other in a series of anastomosing loops to form arterial arcades, single for the upper jejunum and double lower down. From the arcades, straight arteries pass to the mesenteric border of the gut. These vessels are long and close together, forming high narrow windows in the intestinal border of the mesentery, visible because the mesenteric fat does not reach thus far. The straight vessels pass to one or other side of the jejunum and sink into its wall. Occlusion of a straight artery may lead to infarction of the segment supplied because these are end arteries, but occlusion of arcade vessels is usually without effect due to their numerous anastomotic connections. The ileal arteries are similar but form a larger series of arcades, 3 to 5, the most distal lying near the ileal wall so that the straight vessels branching off the arcades are shorter. There is more fat in this part of the mesentery, so the windows characteristic of the jejunal part are not seen, a useful feature in identifying loops of bowel. The end of the superior mesenteric artery itself supplies the region of the ileal diverticulum, if present, and anastomoses with the arcades and with the ileocolic branch to supply the terminal ileum. The veins all correspond to the arteries and thus drain to the superior mesenteric. The lymph drainage of the jejunum and ileum passes back along the arteries to lymph nodes that lie in front of the aorta at the origins of the arteries. Series of lymph node filters lie between the mucous membrane of the gut and the cisterna chyli and juxtaintestinal nodes, superior mesenteric nodes and other preaortic nodes. The parasympathetic vagal supply of the small intestine reaches the intestinal wall with its blood vessels and normally augments peristaltic activity. There are many afferent fibers whose function is unknown. They do not transmit pain impulses which, as with the stomach and other viscera, use sympathetic pathways. The sympathetic supply, which is vasoconstrictor and normally inhibits peristalsis, is from the lateral horn cells of spinal segments T9 and 10. Small intestinal pain is usually felt in the umbilical region of the abdomen. They, both, have influence on the intrinsic nervous system of the gut represented by the plexuses of Auerbach and Meissner. To sum up, the jejunum and ileum constitute the longest part of the gastrointestinal tract. It occupies the infracolic compartment of abdominal cavity. They constitute two parts with similarities and particularities. They are very mobile in the mesentery and are supplied by a rich anastomotic blood supply. Lymph drainage is ensured mainly by the preaortic nodes.